After 40 weeks of anticipation, the mother is in labor. Labor may begin so slowly that some women are not sure if it is actually occurring. For others, the onset is abrupt and unmistakable, often preceded or accompanied by the sudden rupture of the amniotic sac. When the mother arrives in labor and delivery, she is made welcome by the labor nurse, who will provide ongoing care and act as the patient's advocate. The cause of the onset of labor is not fully understood, but it is known that a number of things occur. As the uterus stretches, prostaglandins are released. These hormone-like substances play a role in the contraction and relaxation of muscle tissue. Oxytocin, a hormone directly involved in uterine contractions, begins to be excreted in increasing amounts during the late stages of pregnancy. As the fetus descends into the pelvis, the increasing pressure on the uterine cervix triggers the release of more oxytocin. The cervix, which is normally long, thick, and firm, begins to shorten, thin, and become soft and pliable. A decrease in progesterone allows estrogen to stimulate the uterus's contractility. The placenta has a working life of approximately 40 weeks. Near term, the placenta begins to age, causing it to work less effectively, which seems to trigger an increase in fetal cortisol. This causes the placenta to decrease progesterone production and increase the production of prostaglandin. The actual mechanism that coordinates the muscular contractions of labor is unknown. It is theorized that cells in the top of the uterus, the fundus, transmit signals triggering the contractions. The length of labor varies, although it tends to be longer with the first pregnancy and shorter in subsequent deliveries. Factors which may affect the duration of labor include use of regional anesthesia, medications intended to stimulate contractions, rupture of the membranes, fetal size and position, the maternal pelvic structure, the force of the uterine contractions, and the mother's emotions surrounding the process. Labor occurs in 4 stages. The first stage begins at the onset of regular uterine contractions and cervical dilation, and is further divided into 3 phases. The first phase is the latent phase, when cervical dilation goes from 0 to 3 centimeters. On admission and at intervals throughout labor, the nurse performs a vaginal exam to assess cervical dilation and effacement, and the position of the fetal head. During the first phase, the cervix begins to efface, thinning out by as much as 40%, and moves into a more anterior position. This takes an average of 7 to 9 hours for the primiparous woman and 4 to 5.5 hours for the multiparous woman. The contractions may be so mild that the mother is unaware of them. They occur every 3 to 30 minutes and are often irregular. The contractions are mildly palpable and record a pressure of 25 to 40 millimeters of mercury on an internal pressure catheter. Many women say it feels like menstrual cramps. There may be a light bloody show as the mucus plug is discharged from the cervical opening and tiny blood vessels around the cervix break during dilation. Some women experience short-term diarrhea as the large intestine empties to increase abdominal space for passage of the fetus. The bag of water may break, and the fluid should be clear and free of strong or unpleasant odor. The rupture of the membranes may be abrupt and occur as a sudden gush of fluid, and there may even be an audible popping sound. For other women, the rupture is subtle, resulting in a constant trickle of clear fluid that is not relieved by emptying the bladder. The latent phase is usually comfortable, and the mother is able to ambulate and to chat through most contractions. She may be excited and talkative and appear confident.